and today I'll be talking about thyroxine therapy for benign thyroid nodules. So we all know that benign thyroid nodules are very common. They are mostly asymptomatic, with the clinical concerns being cosmetic reasons, pressure symptoms, and to rule out the risk of malignancy. And we also know the common causes for it are MNGs, Hashimoto's thyroiditis, cysts, follicular adenomas, and HER3 cell adenomas. So at the beginning, I would like to present this data, which was a nationwide survey from America of 1,000 physicians. And to me, it was surprising to see that almost 1/4 of these doctors were using thyroid hormone therapy in suppressive doses for thyroid nodule management. And amongst this included 14% of the surveyed endocrinologists. So firstly, I'd be answering the question, can thyroxine suppressive therapy actually reduce nodule size? So the rationale for this therapy is that thyroxine therapy will lead to decrease in the TSH or suppression of TSH and hence thyroid atrophy. But this is not that simple. The importance of TSH in goiter formation varies with the cause of the goiter. So in regions with iodine deficiency or Hashimoto's thyroiditis, the increase in TSH secretion is the predominant cause of goiter. So giving thyroxine would reduce TSH and hence decrease the goiter size. But in thyroid nodules or sporadic non-toxic MNGs, the thyroid enlargement, we know it is caused by several growth factors, one of which is TSH. So thyroxine therapy alone wouldn't suffice to reduce clinically the nodule volume. Now, I'll back this up with evidence from the literature. And there is a lot of literature on this topic. Most of the literature is old, but the results are very heterogeneous. And the heterogeneity in the results can be because of the population that was studied. Some regions we know would be iodine deficient, some would be iodine sufficient. Also, the population which was enrolled was heterogeneous. And the method which was used to assess the volume of the thyroid nodules was also very heterogeneous. So one of the oldest study was from the USA. This was published in 1987. It was a double-blinded RCT of 53 euthyroid patients with biopsy-confirmed colloid solitary thyroid nodules. They were given either levothyroxine at 3 micrograms per kg per day or placebo for 6 months. And the authors noted no significant decrease in nodule diameter or volume. Another study from Italy, they studied 83 euthyroid patients, again with the palpable STN. They gave levothyroxine at slightly lower doses of 2 micrograms per kg per day or placebo. They followed their patients up till 5 years, and at 5 years, they noted significant difference in nodule volume. But this difference was mainly because the group which was receiving placebo had increase in size of the nodule, whereas the group which was receiving levothyroxine had very slightly decrease in the size. However, the new nodule detection was more in the control group. And in a subgroup analysis, they also noted that nodule shrinkage was more frequent in patients who had complete TSH suppression. This was a study from France. They studied 123 patients with a single palpable benign nodule. This was an 18-month trial, and they adjusted the levothyroxine dose to a lower TSH level of less than 0.3. Again, they had similar results like the previous study with a small decrease in the nodule volume in the levothyroxine group and an increase in the placebo group. But they noted that there was a clinically relevant volume reduction of more than 50% in around 27% of patients who were receiving levothyroxine. A large multi-centric trial from Germany, they studied around 1,000 euthyroid patients, and they divided their participants into 4 groups. One received placebo, the other received only iodine, one received thyroxine, and another received thyroxine plus iodine combined therapy. And they noted that the nodule volume reduction was the greatest in the thyroxine plus iodine group, which was around 17.3% as compared to the placebo group. There is also literature which has studied that whether comparing thyroxine to other therapies. For benign thyroid nodules, we have other therapies other than surgery like percutaneous laser ablation. So this study from Italy compared levothyroxine therapy versus a single session of laser ablation for 12 months. And they observed that the group which received laser ablation had a very significant volume reduction, and there was no significant volume reduction in the levothyroxine group. Also, because I'll be talking later what are the adverse events of giving thyroxine in the suppressive doses. So in 2014, a group tried to study whether giving thyroxine in non-suppressive doses, like we give it to euthyroid patients, but in non-suppressive doses, would that be beneficial in reducing the nodule volume? So they studied around 361 euthyroid women, but we should note that this was not a randomized controlled trial. They gave them levothyroxine to obtain TSH in the range of 0.5 to 0.8, which would not be suppressed. And again, they saw a very mild decrease in the volume size in the levothyroxine group as compared to the placebo group. However, they noted that the mean annual increase of nodule volume was significantly minor in the levothyroxine group. What about the literature from India? From India, I could come across very few studies on this topic. One was published in 2010. This was just a prospective clinical trial where they studied 22 euthyroid patients with benign thyroid nodules. And they gave them 50 to 100 micrograms of levothyroxine to keep the TSH in the low normal range. The authors actually observed a reduction in the size of nodule in around 66% patients, but they did not mention to what extent the reduction was there. But they also mentioned that there was complete disappearance of the nodule seen in 6 patients. These differences could be because the region where this was studied could be an iodine deficient region. So we know in iodine deficient regions, it is more beneficial to give thyroxine in benign thyroid nodules. Another single center cohort study from India was published in 2021, where they studied 67 patients with benign goiters. Again, they gave 50 to 100 microgram levothyroxine. And in this study, they observed that there was a clinically detectable around 20 to 50% change in volume seen in 10% of the patients. Also, there have been multiple meta-analysis of these randomized controlled trials. To mention one of them, this was done in 2005. It included 9 randomized controlled trials. And in this, the authors noted that if we were to study the the relative risk of the number of subjects with more than 50% volume reduction, there was a significant decrease in the number of subjects with more than 50% volume reduction in the placebo group as compared to the levothyroxine group. The NNT obtained from this meta-analysis was 8. That means that to have a clinically meaningful reduction in the nodule size, 8 patients would be required to be treated for 1 patient to actually benefit from the treatment. So what we saw that thyroxine therapy actually does lead to some modest reduction in the nodule volume, then why not just use it? Because we know we will be suppressing the TSH levels for long terms, and long-term suppression of TSH levels, it has been very well studied that this is related with the increased cardiovascular risk in the form of atrial fibrillation, even increased mortality has been seen. And obviously, there is a bone loss osteoporosis, which is more pronounced in postmenopausal women. Other concerns could be the duration of treatment. How long will we continue to give this suppressive therapy? And whether if we withdraw the thyroxine therapy, what will be the behavior of the benign nodules? There's not much literature on this, but one study had seen that after withdrawing the thyroxine, the nodules actually start growing in size again. And also, is it clinically relevant to reduce the volume by around 15 to 25%, which is seen in most of the studies? Is it actually clinically relevant to reduce the volume by this extent of cytologically benign nodules? And as I mentioned before, the meta-analysis had shown that the number needed to treat was 8, which means that 8 subjects must be subjected to the risk of adverse events for 1 patient to actually benefit from it. Coming to what the guidelines say. So the 2015 ATA guideline on management of thyroid nodules, they do not recommend TSH suppression therapy because they say that the potential harm obviously outweighs the benefit for most patients. But they say that in patients who are in iodine deficient regions, iodine supplementation should be given. The 2023 ETA guidelines also say the same, that thyroid hormone treatment is not indicated in euthyroid individuals with nodular thyroid disease. So to conclude, I would say we have to maintain a fine balance. Although thyroxine therapy results in a modest reduction in the thyroid nodule volume, this is at the cost of the potential adverse events, which includes atrial arrhythmias and the reduced bone length. Thank you very much.